Good evening, colleagues, and we welcome you to week 5 of our peer-led neuroscience training series. I am Dr. Mark Muyanga, and it's a pleasure to moderate today's session on anxiety disorders. So over the past weeks, we have journeyed through topics such as depression, substance use disorders, schizophrenia, and last week we tackled bipolar disorder. So each week from Tuesday to Thursday, and for strictly 1 hour, that is from 7 p.m. to 8 p.m., we actually come together to deepen our understanding of mental health through the lens of neuroscience. And tonight, we are turning our focus to one of the most common yet often actually misunderstood conditions, and that is anxiety disorders. And today we are having particular attention to their epidemiology and diagnosis. Our session is going to be led by none other than Dr. Sadat Katama, who will guide us through this important discussion. At the end of his submission, we are going to have a question and answer session. But anytime during the discussion, if you feel like posting a comment or asking a question, so as not to forget, please, you can post it within the chat. So please settle in, stay engaged, and let us make the next hour interactive, insightful, and highly enriching. Dr. Katama, you are welcome to take us away for this evening. Thank you.
Yes, thank you, Dr. Muyanga, for that wonderful introduction. And as he said, I'm Sadat Katama, and I'll be taking us through anxiety disorders. So we shall be looking at the history, the definitions, history not really so much, but the definitions, the diagnosis, and then of course some epidemiology, and we shall give some differential diagnosis. This is one of the most common mental disorders, as Dr. Muyanga said. Anxiety disorders are one of the most common ones, and quite often they go unnoticed, as we shall see. Of course, we shall then look at how they come about tomorrow and then how to manage them on Thursday. Basically, anxiety is an emotion that everyone basically feels. Each one of us has ever been anxious at one point in time, or we've ever been worried or concerned about something. It is, however, what follows this worry or this fear within us that might determine whether this is something that needs medical attention or not. I'll give an example. When you find that you are going to have maybe an exam, you will feel funny, you will feel worried, your heart will beat a bit faster, and so many other things. That is not enough to say that, oh, this person has anxiety and something like that. Yes, you might be anxious at that time, but it is not enough to say that you have anxiety. When you look at this, basically anxiety is more of a spectrum of things. Moving all the way from the basic normal emotions that we might feel. You might fear for something, or you might worry because you have a travel or something. And then there are those other things that might happen that might keep you kind of keyed up, kind of on the edge. And then they drive you to these fearful spells where someone might get some panic attacks until then you get to the point where someone is actually categorized as having an anxiety disorder, a particular one, as we shall be seeing in the next slides. So anxiety basically is an activation of the brain's system where harm may be potentially occurring to an individual, and then how this is interpreted. Fear, on the other side, is basically a defense mechanism, a motivation for the brain to deal with anything that might be kind of worrisome to an individual, something that poses a threat to an individual. It definitely incites fear in someone. So there are so many anxiety disorders, and I'll briefly go through each one of them, not all of them, but for those that we commonly see. This slide here looks at generalized anxiety disorder. But for all these disorders, we shall be looking at what happens on the core, what basically the person has in their feelings and in their mind, what goes on in the core emotions or cognitions. Then the physical symptoms that they feel, things that they will actually manifest outside or that they will experience within them as signs of the worry, and then how they will behave based on these symptoms and these emotions that they are having. Then, of course, for us to determine whether someone has a disorder or not, we shall consider a particular duration and then I will be just showing the time of onset when these usually tend to start occurring. Note that it's not that that is the age where it starts happening, but most patients start experiencing those disorders at that within that age category. So when you look at generalized anxiety disorders, basically someone has this serious uncontrollable worry. They are anxious, they are fearful, they are worried continuously about everyday events, anything that is happening. If they are going to go to work the following day, they are worried about how everything will go to work. If they are going to go home, they are worried about how everything is going to go at home. Basically, they are worried about each and everything. And because of this worry, these individuals can then become restless. Some can be irritable. They find it difficult to concentrate. And as a result, because of this continuous thinking and worry, they will have issues with sleep. You find that they can't sleep well. They are always easily aroused. And this then goes ahead to make them unable to work, unable to interact with others. So because someone is overly worried all the time, they'll even be in a workplace, but the worry overwhelms or overtakes them. And you find that they can't even do any particular productive work at that time. So this then would appear to be a generalized anxiety disorder. But of course, we need a duration of at least 6 months to make that diagnosis. We always worry, but worrying about everything that takes so long and makes you unable to do your activities or work productively would then call for you to probably be assessed or assess someone if they present with some of these symptoms. Then we have panic disorder. This one, basically, an individual will experience recurrent panic attacks. These panic attacks are unexpected, and quite often the trigger might not be known to the individual. So they have an intense fear of losing control, fear of dying. This then leads to a manifestation of a number of physical symptoms. And I'm going to talk about a panic attack specifically later on today. So these symptoms here, someone will have fast heartbeats, pounding heartbeats. They can hear their heart beat in their ears. They sweat, they have chest discomfort. Some of them are dizzy. Some even end up losing consciousness. So these are symptoms of a panic attack. Now, when this happens, definitely the individual will be unable to either work, because imagine this happens, you are at work. Everyone will wonder what was going on. And the next time you'll even fear to go back to work. So this is what happens in a panic disorder, recurrent panic attacks. And you need these to be happening for at least 1 month to say that an individual has a panic disorder. The median age of onset, of course, is 25 years. Then we have other anxiety disorders like agoraphobia. Basically here, someone is basically fearful of open spaces. Someone wonders, if I go to this crowd, what if something happens? How will I escape from there? That is what happens in agoraphobia. The individual may not show any physical symptoms, but they are just worried excessively about what might happen should they go to either an open place or even an enclosed space. So this can make people find it hard to even either interact with others, board some transport means. Someone tells you, for me, I can't manage sitting in a taxi because of, in case something happens, how do I run out of it? How do I escape? And this fear can be so intense. So it can make people avoid those situations that might actually induce those fears. So if someone has a phobia for gatherings, for very many people, you find the person will fail to go to work if at all the work is to do with very many people. They'll fail to go to school and other things. You need these symptoms to happen for at least 6 months before you say someone has agoraphobia. Then we have specific phobia. This one is, I think, one of the most common phobias, basically, or most common anxiety disorders. Someone has an intense fear for a particular object. We've seen people who can even undress if a cockroach jumps over them. And yet, if it's a mosquito, they will not. They will just either hit it or, chase it off, and they go on with their everything. But someone has an intense fear, which is excessive. And it is quite unreasonable. I mean, if a cockroach jumps on your foot, what is it going to do? Nothing much, but someone can fear so much that they can even undress and run around because of that cockroach. So this happens, and when people realize that there is a particular item that they fear in a particular setting, they will try to avoid that setting. So they will have a phobia for those situations where that particular item is. So these ones also do not have particular physical symptoms, but the fear is within. Some people fear blood. I've seen an intern who collapsed because of, it was a medical student who collapsed for the first time she observed a cesarean section. And her reasoning was that the look of the blood made her terrified, and she passed out. So things can happen. People fear injections, people fear places. We need at least 6 months to diagnose specific phobia. Then, of course, we have social anxiety disorder. Here, people basically fear to be judged by others. What if I do this and then people see, what will they say? And then they will find themselves in a situation where they want to avoid that setting. Some will have the urge to pee or even defecate. Like they just can't handle whatever people are going to say, or the scrutiny that might come with what they do or in a particular setting. We need still 6 months to diagnose this. It starts quite early, usually in adolescence, around 13 years. So the worry is usually that they will be negatively judged or viewed by others. So they tend to avoid that. Then, of course, we have separation anxiety disorder. Here, basically, unrealistically, someone worries or fears so much moving away from a group of people, from an attachment figure. For a child, if a child is left by the mother to strangers, or if a child is surrounded by strangers, it is understandable. Maybe 2 years, 3 years, the child will definitely cry looking out for the attachment figure, for someone they know. However, for a person older than 4 years, if this happens all the time, you send a child to school and the child comes running back, and they never outgrow it even when they get to associate very well with the other kids at school, with the teachers and all that. But still, every time the parent leaves, the child gets these symptoms. Some people might get nightmares, some will just have symptoms of distress. So for a child or adolescent, 4 to 18 years, you need at least symptoms to last at least 1 month, while for adults, you need symptoms to last at least 6 months to diagnose this separation anxiety. Then there is selective mutism. This one, more common in children. You find that someone fails to speak in particular situations. So a child is at school, but they can't say anything. Even when asked, someone can't ask a question in class, can't say anything in that situation. But when in other situations, probably they can be able to talk. Here, you may not find any physical symptoms. The issue is usually that it can interfere with either education or social communication. I mean, if someone is attending school, they don't say anything, people will even wonder whether they can even actually communicate, or they need help with sign language, yet actually the person can talk. So that is selective mutism. You need at least 1 month beyond the first month of school for you to diagnose this, and it starts quite early childhood. So I talked about a panic attack. Now, most of these disorders and even others, they might present with a panic attack. Someone will come to hospital with these symptoms that you see: palpitations, sweating, trembling, fear of dying, fear of choking, they feel chills. Basically, so many of these symptoms. And you will run all tests, because when you list these symptoms and you ask someone what could be wrong with this person, they'll tell you so many things. A panic attack would almost always never come through as a differential for the existence of these symptoms in an individual. However, when you find 4 of these symptoms, 4 or more of these, then, and you realize that there is no other physical explanation for the symptoms, then you are right to suspect a panic attack. Now, a panic attack can happen alongside other disorders, like I said. So you may find, and when you find it is happening, it is important that you specify this panic attack. So someone might have depression, but with a panic attack. Someone can have PTSD with the panic attacks. You need to specify that there are panic attacks occurring in this context. Now, all of that I've been saying is mostly from the DSM-5. However, the ICD-11 doesn't really change, doesn't differ much. You find that it has similar category names. You find agoraphobia, social anxiety disorder, specific phobia, panic, generalized anxiety disorder, basically the same things that I have mentioned. And this slide is showing the transition between the classification in the ICD-10 to what we have now as ICD-11. So these are the same things that I have been talking about. Now, when you suspect or when you find that an individual has an anxiety disorder, it's really important that you stage this disorder, basically based on the level of severity. In the very first session of this series, I talked about measurement-based care, and it has featured along other presentations that we've had. In measurement-based care, you rate the patient's symptoms so that you know how severe they are. And then, as you treat these individuals, you keep rating them to see the resolution of the symptoms to ensure that there is remission. So the same thing happens here in anxiety disorders. So you have stages. You have like stage 0, where basically someone just has the presence of a disorder risk factor. of an anxiety disorder risk factor, but there is absence of anxiety disorder, and there is a low anxiety severity. But as you go from stage 0 through stage 1 to stage 4, you're going to find that now you reach where you have someone meets the criteria for anxiety, for an anxiety disorder, and then depending on the duration of the symptoms over a certain period of time, how much of that period is occupied by symptoms. So when you look at stage 2A, less than 30% of that period has symptoms of the illness during a 4-year period. Then with the stage 2B, that is stage 2A, stage 2B, whatever is happening in stage 2A, but there is a comorbid condition. Either someone has major depressive disorder as well, or dysthymia, or alcohol dependency. Now, the difference between stage 2, 3, and 4 is just the duration here. You find that stage 2A is less than 30%, stage 3A is 30 to 80% of the duration having symptoms, while stage 4A is greater than 80%. The individual has basically symptoms for more than 80% of a certain period of time. Then those are on the S. Then the 2B, as long as there is a comorbid condition, then that goes to the B aspect. Now, anxiety. These things we always hear people say these things, or people will come and say, will tell you things in the clinic, and then you're like, maybe your heart is like this, maybe your blood pressure is like this. Yes, you go ahead and you assess all those other things. But it's always important to actually assess these individuals for anxiety. And I'm going to show why we always have to do this. Culturally, there are times when someone will say something and maybe you will misinterpret it, or you will understand it differently from what the patient is saying. It is always important to understand what the individual is actually telling you. In our local context, someone can tell you, neraliikirira nnyo, I worry too much, or I worry a lot. The next question will be, tell me more. This worry can be about a particular thing or about everything. And we have already defined generalized anxiety, we've defined all these other anxiety disorders. It's always important that you follow through with questions regarding the diagnosis, so excluding some of these disorders. Should someone say something like neraliikirira nnyo, ntya nnyo, I feel a lot, I feel ndi ku bunkenke, I feel I'm on the edge. You need to understand some of these things. Then thinking too much, ndowooza nnyo these days. When someone is broke, probably they'll think too much about how to get money and all that. But it is important that you understand whether this thinking too much is because of a particular situation or is actually going on across every aspect of this person's life, so that then you understand how to help them. Of course, in other contexts, they also exist. Now, when you find that an individual might be having anxiety, you will need to rate this anxiety. These tools help with diagnosis as well as monitoring these anxiety disorders. So in terms of diagnosis, in terms of knowing how severe the condition is, and then monitoring the response to treatment. We have seen all these along the way in other presentations. We've always had these tools which we use to understand what the patient is actually going through. So for anxiety, you may use the Hamilton Anxiety Scale. You may use the GAD-7. This is a very brief questionnaire. It has only 7 questions. So it is very easy to use. Then, of course, you have the Beck Anxiety Inventory, as well as these other structured tools like the SKID 5, the Mini. They can all be used in diagnosing as well as monitoring response to treatment. This slide just shows the different tools for specific anxiety disorders. So if you suspect someone has generalized anxiety disorder, you'll find what to use, social anxiety, and then others. Then this slide, I included it because it is helpful when you look at these. It is specific measures. When you click now here on the severity measure for separation anxiety disorder for adults, it will give you a link which you can go to, and you find the questionnaire or the tool to use for that particular condition. So for panic, for agoraphobia, and others. This is very important, especially whether you are in a general setting or you are in a psychiatric setting. You need to assess patients for this, for reasons that we shall be talking about. Then after you have assessed this individual's severity, you need to assess the functioning of the individual. How much are these symptoms affecting this individual? Their life, work, family, social interactions, school, and other areas of functioning. So you can use the Sheehan Disability Scale, you can use the HUDAS, the Quality of Life Enjoyment and Satisfaction Questionnaire. These days I hear people talk about enjoyment. So you might have actually to use this to know whether this person is actually enjoying their life or not. And this will be based on the anxiety that they are having, the symptoms that they are having in their life. So then it can help guide you on how much effort you need to put as far as managing this individual is concerned. How common are anxiety disorders? Anxiety disorders are among the most common mental disorders worldwide. Of course, the range is between 10 to 14% in this is now globally, and you find that it is more common in women. Anxiety disorders are more common in women than in men, up to 2.4 times. And usually they start in the early stages of life, before 20 years, and then they go on increasing. In 2019, up to 800 million people worldwide were estimated to be affected by anxiety disorders. And the funny thing is that only about 1 in 4, that is 25% of individuals with anxiety actually receive treatment, which means 75% go on with this anxiety unrecognized or untreated. And this shows you the need to always assess our patients for this anxiety. If you find you have this constant worry that is not going, it is also fine for you to go and get assessed. That is very vital. In our setting, I looked at some review that looked at anxiety disorders in Uganda, and for children and adolescents, it was at 14.4%, while for adults, it was at 20.2%. This is serious, and we need to pay attention to it. Imagine you see 100 patients in a year, 20 of them have anxiety disorders. How many times have you assessed patients for anxiety? We need to always do these assessments because they are really, really vital. And they commonly co-occur with other conditions, as we are going to see. Now, from the beginning, we talked about I think it was first week we looked at depression. Second week we looked at addiction and substance use disorders. Then, so we're going to see that all of those conditions are relatively less common as compared to anxiety disorders. This is something that we need to give a good ear to. Now, anxiety disorders can occur they can occur singly. It might be just a social anxiety disorder, or they can occur along other anxiety disorders. So this study basically looked at the co-occurrence, the comorbidity of anxiety disorders, as well as other mental disorders. So you find when you find people with depression and then having these other anxiety disorders, here you're going to find the numbers that will have those other conditions. So it is important that when you're in the clinic and you find someone has a particular condition, always assess them for other conditions. When we were presenting about depression, still we talked about this. About addiction, we have always talked about the comorbidity, the co-occurrence of these conditions with other conditions. Now, this study basically looked at development of a particular physical illness or physical morbidity in individuals with anxiety disorders. Now, I want us to pay close attention to this, because this is why I was saying that reason why we need to actually assess our patients for anxiety. Now, this study reported the hazard ratio. Hazard ratio is basically how likely an individual or a group of individuals is likely to develop or to have a particular condition from or an event at any given point in time in relation to another group or compared to another group of individuals. Now, when someone has anxiety, an anxiety disorder, the chances that they will develop hypertension is up to 40%. So should someone come to you and they have anxiety and you don't catch it and you don't manage it, then the chance that they will develop hypertension is up to 40%. This was an analysis, a meta-analysis of 59 studies, all showing a hazard ratio of 1.4, up to 40% can actually develop hypertension. Then, of course, we have other conditions. 52% for cardiovascular disease, 19% for DM. Then cognitive decline, we find the hazard ratio is 1.77. So we need to give attention to diagnosing anxiety disorders. And even having those physical conditions can actually trigger an anxiety disorder in an individual. So this is something that we need to pay attention to when seeing the patients in our general, anywhere that we see patients from. They can develop somatic conditions because of the anxiety, or they can even develop anxiety because of the somatic conditions. Someone is diagnosed with diabetes and then they start worrying all the time they're going to die, maybe they will not live for long, and then everything and all that, because probably they have read about the impact of diabetes, and then they keep worrying and worrying and worrying. And then tomorrow we shall be looking at those cognitive models about how this worry can then lead to another worry, and then lead to a cascade of events that basically can maintain this anxiety. Here, I'm looking at the impact of anxiety disorders on society. Now, imagine you are in the clinic and you see a patient who has only anxiety disorder. The chance of having suicidal ideation will go between 5 and 10%. If you find someone who has only major depressive disorder, suicidal ideation will be between 15 and 20%. However, should you have a combination of major depressive disorder and anxiety disorder, the suicidal ideation will be between 25 and 30%. This tells us the need to always assess. Don't just ask questions about depression only. It's important that you always ask about these other conditions like anxiety, because it increases the risk of suicide and even other somatic conditions. The same thing with suicidal attempts here. You find that depression, anxiety disorder alone, suicidation is quite low when for major depressive disorder alone, but when you look at a combination of them, it can go as high as 5%. So we need to pay particular attention to anxiety. What are some of the differential diagnoses for anxiety disorders? So these can be psychiatric or somatic or physical. For the psychiatric, anyone with major depressive disorder can come in with anxiety, they might have worry, they might be agitated, they might have sleep disturbance, poor concentration. So you might actually, someone might first think, oh, this is just depression, or this is just anxiety, and they forget about assessing for a depression. We talked about bipolar affective disorder. I think that was last week. And if anyone who attended that session should be able to tell that, oh, it can actually be confused with anxiety depending on the stage at which a patient presents. Then, of course, OCD. So in the earlier versions of the DSM-5, this now like obsessive compulsive disorder was actually categorized under the anxiety disorders. But of course, with the new classification, this has been moved away. Someone has this ritualistic repetitive behavior to deal with a particular fear, because they know that surfaces are usually contaminated with germs. Every time they touch somewhere, they'll have to wash their hands. Every time they touch somewhere, they'll have to wash their hands because of the fear that they will get an infection from the surface they touched. So this can actually be confused with anxiety. Then, of course, we have PTSD, then health anxiety. Someone has an illness, or they are worried that they might have an illness. And some of them actually can even get the typical symptoms of that physical condition, which actually, even with repeated investigations, are usually negative. Then, of course, substance use. People will come in sweating, palpitations, some with panic attacks because they are intoxicated or they are withdrawing from a substance. You need to always assess and be sure that you're not dealing with a substance intoxication or withdrawal when you're considering anxiety disorders. Then we have the somatic conditions. I've talked about some of these substances, but then individuals with hyperthyroidism, they usually have palpitations, tremors, they can have weight loss, but of course they have these other symptoms that go along the line of hyperthyroidism: heat intolerance, the ocular signs, So you need to actually be able to assess. Actually, when you're doing an assessment, you need to rule out these possible causes of the symptoms that the patient might actually be presenting with. Then you can have things like a pheochromocytoma. Of course, here, usually these individuals have hypertension that is mostly refractory to most antihypertensives. Diaphoresis, headaches, palpitations, panic attacks can also occur there. Here, you'll have to look for 24-hour urine catecholamines, and then you assess and manage accordingly. Then someone with a cardiac disease can actually present with some of these symptoms. You might have to do an echo, an ECG to rule out some of these conditions. Mitral valve prolapse can also present similarly. Then some people with some respiratory diseases like asthma, COPD, they might have those might present with air hunger, shortness of breath, basically some symptoms which actually occur in a panic attack. That's why someone having a panic attack will always present the A and E, and then all these tests will mostly be done. But you'll find that most of the time the investigations will be normal, and then people will start to wonder what could be wrong. Then, because the person is not satisfied with the explanation they've got with the findings of the results, from there, they walk direct to the next clinician to be able to probably diagnose something else or to find a diagnosis, because the other side they didn't explain that, oh, this could be a panic attack, and a panic attack happens like this, and this is how it is managed. And it has a tendency to recur even without a particular physical trigger. So you need to pay attention to these patients who come in. If you do tests and everything is negative, please, the questionnaires, most of the questionnaires I show are usually freely accessible. Some are patient rated, some are clinician rated. You can use them. And then you point out to see whether this individual is actually having a panic attack, an anxiety disorder, or it is a physical condition. Then individuals with epilepsy, these ones can also present with emotional symptoms, which might include actually anxiety. So any patient you see, it's important that you assess them for these anxiety disorders. So in summary, basically, anxiety or fear-related disorders, those that you see, and we've talked about all these: separation anxiety, generalized anxiety disorder, selective mutism, and others. Whether you're using DSM-5 or ICD-11, you're going to find that the classification is quite similar, and the presentations are usually, the symptoms, they are usually similar. You should assess the patients, you should rate their symptoms. Always rate the symptoms using the scales that I have shown, and of course there are other scales that you might have to use. And then it is important to identify any other possible cause of the symptoms, because the symptoms you find in anxiety actually present a lot in other medical conditions. It is necessary that you pay attention to rule out those other physical illnesses. And if someone comes with a physical illness, it's important that you also assess them for some of these comorbid mental disorders, because they can delay recovery, they can delay rehabilitation, they can worsen the outcome when you are managing the patient. This has been the talk on anxiety disorders. Thank you very much for listening.
Wow. Thank you so much, Dr. Katama, for that timely and crisp presentation. It has certainly left us better than we started off. And it would boil down to reason if I didn't thank the 92 participants I am seeing for logging in. We thank you so much for being lovers of new knowledge, and we don't take that for granted. Our colleagues, it's time for Dr. Katama to once again get on the hot seat. We have a number of questions, and in case you also have any question that came up during the course of his presentation, please feel free to post it in the chat, and he will have to respond accordingly. Dr. Katama, I'm seeing Dr. Bongomin Bodo has raised a hand. Mr. Bongomin, I'm humbly requesting that in case you have any question, please type it out and post it in the chat, and we shall respond accordingly. Thank you so much. So, Dr. Katama, the first question, but anyway, let me ask you, are you ready or you need some
No,
seconds
it
to
is
take
okay.
in some air?
It is okay,
You are
please.
ready?
You go
All
ahead
right, all
with the
right.
questions.
So the first question is from Musa Mahmoud, a doctor. So he has said that given the high prevalence and overlapping symptoms of anxiety disorders with other psychiatric and medical conditions, how can clinicians improve diagnostic accuracy and early detection to ensure timely and effective intervention? Beautiful question. Dr. Katama, over to you.
Yes, Mohammed, thank you for that question. This is really a good one. So, yes, we have this high prevalence of of these conditions, and they often overlap with other medical conditions. One thing about increasing the diagnostic accuracy and early detection is now like what we are doing today. When we are discussing this, we are not only discussing with psychiatrists, we are discussing with everyone in the medical fraternity who manages to join in. The idea is to create awareness that these conditions are actually highly prevalent in our patients and to encourage everyone to always suspect them or even always assess for them when they encounter patients. Anyone who comes with any particular medical condition, they will always be worried about what next, what will happen, what if it is a terminal illness, will I get out of this? So they will always have certain worries. It is always important that we ask symptoms about the worry, the fear, and all that, but also we always mention these diagnostic tools because most of them are freely accessible. You just search GAD-7, it has only 7 questions. The patient will just answer the questions within like less than 5 minutes, and that is it. Then you get the totals and you see where the individual lies. On that GAD-7, there is a question down there which it asks the patient to choose how affected their life is based on the symptoms. And they always choose for you. So it is really not so hard to measure or to actually suspect and diagnose these conditions. The challenge is that people always don't pay attention to these conditions. So we need to just be diligent and we always assess our patients. Thank you.
Thank you so much, Dr. Katama. And I think that is why we have made these sessions accessible to all forms of cadres. We have psychiatric nurses in the chat. We have students. We have psychiatric clinical officers. We have SHOs of psychiatry and other disciplines. And that is because the knowledge of these disorders actually is not the domain of psychiatrists alone, but every clinician out there needs to actually know them. So, Dr. Katam, I agree with you a lot that actually one of the efforts, what we are doing now is literally one of the efforts to make sure that all cadres understand these disorders, because you can only diagnose what you know in the first place. So I think what you have stated is very true. And Muse, thank you so much for that great question. And Matama Shamila is asking that Dr. Sadat Katama, what would normal developmental anxiety look like at different ages, especially if we look at separation anxiety disorder and selective mutism?
Okay. Thank you, Shamila, for that question. So let me start with the separation anxiety disorder. So I said that separation anxiety disorder is diagnosed after the age of 4. You expect that after 4 years, a child should be able to be left, one individual should be able to be left even like let's say at home, or if a visitor comes, the child should be able to actually cope with the situation that is going on at that time. So below 4 years, you find that a child, if the mother disappears from the child will start crying looking for the mother. that is normal anxiety, because they are trying to look for the attachment figure. That's where they feel secure. So in situations where this goes on, actually, I think 2 weeks back, I saw a 32-year-old who has started experiencing this separation anxiety, whereby he stays at home with the wife, but every time he has to go somewhere, he ends up not going, because his reason he said was he always feared what would happen to him when the wife wasn't there. And if the wife had to go to work, still he had the same problem. How would I stay alone at home when the wife is at work? And it had made him stop going anywhere, and he didn't even want the wife to go anywhere. So at 4 years and above, should this be happening a lot, then you would definitely know that this is an issue that needs to be assessed. When you look at selective mutism, of course, a child might fail to talk to strangers because maybe they don't feel secure with them. However, after about 5, 6 years, if a child is taken, for example, to school, they should be able to communicate. They should be able to play with others. So you find that an individual actually chooses, like, does not communicate, does not talk, does not speak in particular situations, but only speaks in others after the age of 5, then you would start suspecting. It might start before 5, but then clearly being diagnosed later on. So these they occur at different stages or age groups based on the individual. But of course, we have to put into mind about the cultural perspectives. Because some of us, when we were growing up, you were not supposed to go and play around the elders or even to just talk to the elders. It might be different for other people. I mean, someone as old as 3 years, they can run around. 4, 5, 6, they can run around and go about everything normally. So, yes, it depends on the age and also the culture. Thank you.
Thank you, Dr. Katama, for that good execution of that question. Before I go to Bongomin Bodo, Dr. Wesige Brian is asking us about pharmacological management. So, Dr. Wesige and colleagues, this is a 3-day session. Today we have handled epidemiology and diagnosis. Tomorrow we shall be delving into the neurobiology to help us to understand in simple and relatable terms what happens in the brain in someone who has an anxiety disorder. And then on Thursday, Dr. Brian, I hope you'll be around. We shall delve deeply into not only the pharmacological management, but the holistic, that is the biopsychosocial management of this disorder. So, and then colleagues, kindly note that most of the videos, most of the recordings of these sessions are now available on our YouTube channel, and we have been sharing it on our chat. So as the saying goes, please visit our channel, like it, and subscribe. Thank you so much, and share it with whoever you can share it with. Then Dr. Katama Bongomin Bodo said, it is clear that there are quite a number of tools out there for diagnosis and measuring severity of anxiety. Which ones would you recommend for 1, diagnosis, 2, measuring severity? Have some of them been validated in our setting, and how have their performances been? 3, these are a lot of questions. How can we promote the use of some of these tools to improve the diagnosis, screening for anxiety in primary healthcare setting, particularly in the non-psychiatrist professional seeing these patients? So, Dr. Katama,
Yes.
if you can
Um,
shoot off.
yes, thank you, Bodo, for these questions. So yes, I mentioned a number of screening tools, diagnostic tools that we can actually use. Many of them that I mentioned, they were actually free. They are freely accessible. You can use it to rate a patient as long as you're not doing it for commercial purposes, that maybe you're reproducing it for your research or whatever. Some of them are actually free. So for diagnosis, I mentioned a couple of them. You could use the structured clinical interview for DSM-5, the SCID, and then you can use the mini international neuropsychiatric interview. This one has basically the SCID and the mini, they assess for a number of these disorders. So you can just choose a section that you want to use on a patient. But then we have these other ones which are specific. Now, like the GAD-7 assesses just for generalized anxiety disorder. Then you'll find things like the Hamilton anxiety, then scale, then the Beck's anxiety inventory. Then we have something called the hospital anxiety and depression scale. That one assesses for both depression and anxiety for patients who are actually admitted in hospitals. Now, the choice is basically upon you. About the validation, some of them have been used in our context to assess, and they have provided similar findings, only that they have not actually given only a couple of them have been actually validated. Of course, research is still ongoing, and possibly Dr. Myanga might come up one day and he validates something for us based on his work that he has done, where he translated the meaning into sign language. Probably will do a lot more about this. Then about how we can promote the use of these tools. This is what we talked about in the very first question when we were responding. We need to actually to start doing this, whether we are psychiatrists, psychiatric nurses, or general practitioners, anywhere, we actually need to act on this and always assess our patients, because these tools are freely available. Thank you.
Thank you so much. Now, Dr. Katama, there is someone here provoking you, and I know your love for football is unchallengeable. It is still Bongomin Bodo. He's saying that there is a footballer who used to play for Arsenal Football Club. He was called Dennis Bergkamp. I'm sure you know him, the skill minstrel. He had a fear of flying and always missed matches that involved flying. And he's asking that which are some of the most difficult to treat specific anxieties?
All right, thank you, Bongomin, yet again. So this is a very wonderful question. So I talked about these specific phobias, and I said these are the most common anxiety disorders. Like this is the most common one. When we are looking at the treatment principles on Thursday, we shall look at how to deal with some of these. We shall look at things like exposure therapy. We shall look at the cognitive models that are involved in setting off the symptoms in these individuals, and then what to work with when managing these individuals. So I request that this question, you tune in on Thursday and we shall have answers about this. But yes, these are the particular anxiety disorders. The challenge with the management is usually, first of all, identifying, diagnosing, identifying the triggers, and then you go ahead and deal with the specific disorder. But on Thursday, we shall be dealing with all this. You do not want to miss. Thank you.
Thank you, Dr. Katama. As you prepare to properly dose us on Thursday, give us a dose is what I'm meaning. So there is a study that was carried out 2007, 2008. There's a gentleman called Choi with his team, and they found a number of specific anxiety disorders. One of them was actually what Bergkamp was experiencing. That was the fear of flying. Then there is what they refer to as the blood injury injection phobia. And this one involves some form of vasovagal response. So as they're injecting you, so someone ends up fainting. So this one actually complicates exposure therapy a lot. Then we have claustrophobia and height phobia. So some studies have been actually carried out. to that effect, but you'll certainly enlighten us more on Thursday. Ladies and gentlemen, we thank you so much for having been with us for this time. We are dedicated to only taking 1 hour from you every Tuesday, Wednesday, and Thursday till we finish our series in the 7th week. Thank you, and let us see each other tomorrow, same time and same link. Thank you, Dr. Katama, and the rest of the team for having made this possible.